Hello, we are the Patellofemoral Structure and Muscular Support Group. I'm Catherine.
I'm Christine.
And I'm Andrew.
And I'm Jordan, cameraman.
Okay, so we'll start with the structure of this joint. It's a diarthrodial gliding joint that contains the posterior surface of the patella and the trochlear surface of the distal anterior femur. Due to the shallow and incongruent fit, which you can kind of see here, between these two bones, the stability of this joint is really dependent on the soft tissues and ligaments and things that surround it. So the patella itself, which you can see right here, is a sesamoid bone, and it rests on the trochlea of the femur. It's extremely mobile and moves around a good amount within this joint. It has a thick articular cartilage on the posterior aspect of it, and the main function is to increase the leverage of the quadriceps muscles and protect the anterior knee joint.
Right, so a little zoom in here, you can see the trochlear notch is not that deep, so it's a shallow structure. So like mentioned earlier, we're going to depend on all the soft tissue structure. So just to zoom in, you can kind of see how the fit isn't that great.
Next, we'll talk about the ligaments of the joint. So there's 4 different ligaments, and they aid in the stabilization and the support of the patella. And these ligaments prevent subluxation and dislocation of this knee joint. The 4 ligaments include the lateral patellofemoral ligament, which you can see right here, the medial patellofemoral ligament, which is right here, the lateral patellotibial ligament, and the medial patellotibial ligament.
And here we have the static restrictions of the joint. We have the medial retinaculum, which prevents that lateral displacement of the patella. The lateral retinaculum prevents the medial displacement. And then the lateral structures are normally a lot stronger, normally because of that area is a lot more exposed. So you are more likely to see that patellar dislocation laterally because you have those stronger ligaments pulling that patella that direction. And the dynamic restraints of the joint, so those are the muscles. We have the quadriceps femoris, which contains the vastus lateralis, vastus medialis, oblique fibers, and the vastus intermedius, which is found underneath the rectus femoris, which is also in the list. And we have the quadriceps tendon right here, and the interpatellar tendon.
A little bit of the structure of the joint. Now we're going to look at some movements that these structures allow. So it's a gliding joint with 2 degrees of freedom, one being superior-inferior glide. So this is associated with flexion and extension of the knee. And then we also will have some medial lateral movement, such as that. So how the structure is going to affect the function. So one big part of the patellofemoral joint is the patella lying within the quadricep tendon. So this is going to provide a mechanical advantage and allow for an increase of knee extension by about 50%. The tracking pattern also helps to minimize forces placed on femoral condyles, so that's another structural thing. So with knee flexion, as the knee goes through the motion, the patella is going to kind of articulate with different surfaces. So to begin with, it's going to move proximally and with a lateral shift. And this is going to engage with the trochlea at about 30 degrees, and it's going to remain stable there due to bony restraints, so kind of holding it in place. As flexion continues, the tibia is going to internally rotate, and the patella is going to move upward. At about 90 degrees, the patella is going to contact the lateral and medial femoral facets, and then finally, at almost full flexion, 130 to about 135 degrees, the medial facets of the patella are going to contact articulating surface of the femoral condyles. That's going to be the full range of motion.
So some things that can go wrong with patella is patella tracking disorder, which is basically exactly as it sounds. The patella shifts out of the trochlear groove, and the shift is usually lateral but can happen medially. So this is a really good picture. Usually it sits nicely in the femoral groove, and then with the tracking disorder, it just won't glide in that groove, and you'll get some more bony contact that should not be there. So how does this happen? Usually it's a combination of things. Such as a weak or tight quadriceps. As we talked about, it's very much linked to the muscles of the tendon of the quadriceps. You can also have tight or loose ligaments, not keeping things stable. Usually it happens over chronic use, so running, that sort of thing. And then even with consistent twisting motions, because that will kind of knock that out of the groove. And of course, a direct acute blow to the knee, or just if you have an anatomical misalignment, that kind of puts you more at risk for that. So symptoms, as I mentioned, it happens a lot of time with activities as you're bending and extending that knee. So activities such as running, squatting, walking downstairs is usually where you would feel that pain. And the pain would feel like a catching when you move your knee, or grinding or popping. It can kind of vary. And then also the sensation that your knee is going to kind of give out. If I would expect that'd be more in a more severe case. And then basically where that pain is just right where the patella is. So pain in front, right here. So in a healthy patella, when you have flexion and extension, if you can see, this ridge right here will stay in the femoral groove. However, with patella tracking syndrome, again, it usually moves laterally. So then when you bend, it'll kind of come here and you'll have more articulation than you should. So it's off to the side a little bit versus in here.